Again, I'm Frank Cuozzo, Naval Hospital, Portsmouth in Virginia. Thank you so much for allowing me to present this topic about gender matters, exploring arterial vascular disease in women. I have no disclosures. We can approach arterial vascular disease in women using two subcategories. One, where arterial diseases that are significantly more prevalent in women, and then arterial diseases where there are obvious and significant gender-related differences, including lower extremity peripheral vascular disease, carotid artery stenosis, and abdominal aortic aneurysmal disease. So we've already heard today about fibromuscular dysplasia. 90% of these cases are in women. It is a very interesting disease. It is non-atheromatous. It is non-inflammatory vascular disease, and it targets layers within the vessel walls of the artery. It's the most commonly affects the renal and carotid arteries. It's the second most frequent cause of renal artery stenosis. There is a strong association with smoking. There may be a familial or genetic inheritance pattern with it. There's multifocal and unifocal classification, with the unifocal more common in children. It involves fibroplasia of the intima, media, or adventitial layers, and it causes this repetitive dilation and stricture pattern in the vessel walls, leading to this string of beads appearance. Imaging can be evaluated with duplex ultrasound, CTA, MRA. Angiogram is the gold standard, and we can see a representative angiogram here of that string of beads appearance. The treatment, again, is conservative. In terms of intervention, angioplasty works very well for this. As you can see, the vessel wall builds up this dysplastic tissue within it, creating vessel obstruction. There's these little septi that occur that actually respond very well to angioplasty. I'd like to discuss median arcuate ligament syndrome by using a recent case that we did. Median arcuate ligament syndrome occurs 3 to 1 in females in the literature. However, as a Navy vascular surgeon, my patient population is a little bit younger, and we see a lot of this, and I have never diagnosed it in a male, just all females. This is a case of a 31-year-old who we treated. She used to be a professional figure skater. She has become debilitated by her abdominal pain. She has postprandial abdominal pain and pain with exercise. She's lost weight. She had a significant medical history, some mental health disease. She had some epilepsy episodes and a hyperreflexible Ehlers-Danlos syndrome. I was so worried about her that I actually sent her for genetic testing to make sure that she did not have vascular Ehlers-Danlos syndrome, as I probably would have sent her to a center of excellence for that. Brother also had MALS. Now, in median arcuate ligament syndrome, it involves the fibrous edges of the diaphragmatic crura. And in approximately 10 to 20% of the population, these fibers can compress the celiac artery. Now, only less than 1% of these patients or these people have symptoms related to it. And the greatest compression occurs during expiration, when your aorta actually moves up, and it causes even more compression. And the result is abdominal pain. And the cause, the underlying etiology may be ischemic, but I think more it's probably neurologic, as the celiac plexus lives there, and it's compressed as well. Can be diagnosed with duplex ultrasound, and here's our patient's duplex ultrasound during inspiration, essentially normal velocities, and then with expiration, these velocities jump to 359 centimeters per second, so incredibly significant change. Here on CTA, from a side view, here is the origin of the celiac artery. This is a classic kind of U-shaped pattern that these patients tend to have. They have severe stricturing at the origin, and then they also have a post-stenotic dilatation that you can see in the celiac trunk. This diagnosis is a diagnosis of exclusion, meaning you have to rule out any other possible GI underlying etiologies before you can offer these patients any treatment. So we sent our patient for all of them, and they were all negative. And then once we were sure that there was not an underlying GI issue, we sent her for a celiac plexus block. And so we sent her to our IR colleagues. that from the back, inject anesthetic around the celiac plexus. The procedure is both diagnostic and therapeutic in nature, and most importantly, if the patient's symptoms resolve after this, then they are considered good candidates, surgical candidates for a celiac artery decompression. And so she said she got relief and she was actually able to breathe after this procedure. So I used to do all these procedures, the decompression procedures open, until my robotic surgeon there in the middle, Dr. David Royney, convinced me that we need to do this via a robotic approach. And since Dr. Royney has been accepted for a vascular fellowship next year at Greedy, I agreed with him. This was our first case that we did. We're setting up the robot here. This is at the aortic hiatus. You can actually see the fibers of the right and left cruce coming down right over the aorta. The aorta here is exposed, and with a little hook, a cautery, we are actually taking down the muscle fibers of the crura until you come to the origin of the celiac artery, and then we start to divide the nerve fibers of the celiac plexus. And finally, here is our completion dissection, where we have circumferentially released the celiac artery. Post-operatively, the patient said that she was able to take a deep breath for the very first time in her life. She was discharged on post-op day 1, eating a regular diet and very happy. Now, you can't have a talk about peripheral artery disease in women without acknowledging that there are potential gender discrepancies in peripheral arterial disease. So much so that in 2012, the American Heart Association made a call to action to address these gender-related issues, and they noted that they need to raise clinical awareness, focus treatment plans, and expand research efforts. And there is a complex interplay of clinical, biological, and societal factors that are potentially responsible for these gender-related inequities in the treatment of peripheral vascular disease in women. And some of these factors are listed here. We know that generally there's a higher prevalence of peripheral vascular disease in men, but then it equalizes after menopause. They have atypical or absent symptoms. They have lower rates of intermittent claudication. And then women are more likely to present initially with acute or chronic limb-threatening ischemia. Here's a case in point. This is a 65-year-old female with a history of only hypertension. She presented to our emergency department with 3 days history of basically right foot numbness, cold, pulseless, very cool. She had a history of a bunionectomy 8 months ago and said that her pain was really gotten worse since then. No history of smoking. Like I said, hypertension. She had negative for any familial clotting disorders. And so on a staging class of acute limb ischemia, she was a Rutherford class 2B. So we took her to and did an angiogram, and this is our initial shot. So we see what's missing is a superficial femoral artery that's supposed to live right here. We then, her below the knee popliteal artery reconstituted, but then there was a cutoff and she actually had no flow down into her tibial arteries whatsoever. We were able to pass a wire fairly easily down into her tibial arteries and performed an angiogram here showing additional clot formation. So we decided to treat her with an ECOS lytic catheter. We placed it from the origin of the superficial artery to the mid-posterior tibial artery. We primed it with TPA and ran her at 0.5 milligram per hour for about 15 hours. It gave her a total of TPA of 10.5 milligrams. We then brought her back the next day, performed an angiogram, and revealed her SFA was now open, but she had significant stenotic disease in about the mid-superficial femoral artery, which we treated nicely with a bare metal stent. Below the knee, you can see that most of her tibial flow reconstituted with the exception of her anterior tibial artery. And the posterior tibial artery went down to the foot, but as you can see, that's not a normal artery distally there. And we did finally get some decent perfusion to her foot. She was very happy, had a palpable pulse at the end of the procedure, and went home the next day. So women in peripheral vascular interventions, this is some data-driven observations. In open bypass procedures, women are more likely to have dehiscences and infected wounds. There's been observations made with hormone replacement therapy that it's been shown to decrease patency rates for both bypasses and in iliac stenting. However, for infrainguinal disease, women appear to have equivalent outcomes after endovascular interventions. When it comes to carotid stenosis, the carotid arteries are typically smaller, and the plaque morphology is different. They're actually more focal plaques and result in higher velocities on duplex ultrasound. And in women, carotid plaques are a greater predictor of just overall generalized atherosclerotic disease. And there's actually a strong link between osteoporosis and carotid disease also seen. Now, the indications to treat carotid disease have been largely shaped by these landmark clinical trials that were performed over 20 years ago. And you'll see that women were underrepresented in these trials. Now, these studies were not powered to evaluate a female cohort, but they did identify several trends in females. And essentially, those trends were, one, the stroke risk benefit was less for women after carotid endarterectomy, and their perioperative complications were higher. And with conservative management, their overall stroke risk was less. And women who undergo carotid endarterectomy for asymptomatic disease may need longer follow-up times to really see a difference in terms of stroke risk benefit. What about aortic disease in women? We do know that the infrarenal aorta is significantly smaller in women. And after menopause is when women have the greatest risk of aneurysmal growth and rupture. It's when the aorta becomes less compliant. The rupture rate is 3 times higher in women and occurs in smaller aneurysms. 34% of ruptured aortic aneurysms that result in death in the United States occur in women. However, only 22% of elective abdominal aortic aneurysms are performed in women. So this means that women with aortic aneurysms are either not being diagnosed or the repair is not being offered to them soon enough. When it comes to aortic repair, we know that endovascular treatments are offered less frequently to women, and it may be because their anatomy is not conducive to endovascular repair. And some have even gone so far to say that our aortic devices are more designed for males than for females. They have more access-related complications and limb occlusion after stent graft placement, more endoleak complications, and in open repairs, their perioperative mortality and hospital stay is longer. So in summary, there are many more female octogenarians than males. And as our society continues to age, this is something that we need to consider in the treatment of arterial vascular disease. And we need to acknowledge that previous research in vascular disease women have been underrepresented. And it's our responsibility as providers to develop expertise on the natural history, disease patterns, and outcomes of treatment to provide optimal care for women with vascular disease. Thank you very much.
Good afternoon, everyone. Thanks for having me back again this year. My name is Mitch Dizon. A little bit about my background. I am a board-certified OBGYN. I completed an OBGYN residency training, followed by subspecialty training in minimally invasive gynecologic surgery. So that is what I do. That's my disclaimer. I do not personally perform uterine fibroid embolizations, but I see a lot of women with fibroids, and UFEs go into my counseling as treatment options for women with fibroids. So we're going to talk a little bit today about UFEs and how I counsel women and what they're good for. So real briefly, what are fibroids? Fibroids are benign, smooth muscle tumors of the uterus. They're also known as myomas or leiomyomas, and these are the most common gynecologic tumors in women. A lot of women actually have fibroids. Thing is fibroids can be extremely small. They can be as small as half a centimeter, but then they can be as big as bowling balls. And so a lot of women have fibroids, and a lot of women are actually asymptomatic, which is great. But regarding fibroids, they are the most common indication for hysterectomy, which is the most common surgery that I perform. Approximately 200,000 cases or 200,000 hysterectomies are performed every year. The exact causes of fibroids are actually unknown, but we think that there's likely a genetic predisposition and that fibroid growth is hormonally linked. In African American women, symptoms of fibroids tend to occur at earlier ages. Fibroids usually grow more quickly, and they usually result in more symptoms. Fibroids grow based off of genetics and based off of hormones. The main hormone that affects fibroid growth is estrogen. A lot of other, there are a number of other things that can cause fibroids to grow, like growth hormones, micronutrients, and then major stresses. So what are the main symptoms of fibroids? The main one that I see, the main one that women are referred to me for is for heavy menstrual bleeding. But other symptoms can include very, very painful periods, a bloating or protruding of the belly, and then infertility. So certain types of fibroids can cause reproductive dysfunction and the inability for a woman to get pregnant. Certain fibroids can also cause pelvic pain, and if they get big enough, they can also cause like frequent urination or urinary incontinence, as well as constipation, just by the nature of the bulk symptoms of large fibroids putting pressure on the organs down in the pelvis. So fibroids can occur in a number of different locations, either outside or inside the uterus. So when I talk to women about UFEs, then the main ones that I feel that UFEs can actually treat are the intramural fibroids, which are the fibroids that are actually in the muscle of the uterus, the subserosal fibroids that are under, I guess you could say, the outer lining of the uterus, and then the submucosal ones that are either in the cavity of the uterus or partly in the muscle of the uterus. These pedunculated fibroids come off of a stalk, and those are best treated by a procedure that I perform called a laparoscopic myomectomy. So you can see UFE can treat a number of the different types of fibroids. Fibroids are typically diagnosed a few ways. One way is a physical exam. Okay, so if they're big enough, then you can feel them like right through the abdomen, or they can be very, very obvious, looking like a woman is pregnant. Ultrasound is typically the first line imaging option that we get to help diagnose fibroids. Pelvic ultrasounds are accessible, they're typically low cost. The drawback of them is not everyone is really good at doing pelvic ultrasounds. But the best ones, or the best types of fibroids that pelvic ultrasounds can see are the submucosal fibroids, which again are the ones that are in the lining of the uterus, or the intramural fibroids that are in the muscle of the uterus. So pelvic ultrasound certainly has its place. The gold standard for imaging for fibroids, though, is the MRI. So it is the most sensitive test, and then it's particularly good for small fibroids. So in any kind of procedure that I recommend or that I perform that will spare the uterus, so keep the uterus in, but will treat fibroids either by this, UFE or by the myomectomies that I perform or removing fibroids, the MRI is typically the imaging study that I will get. So it can show the fibroid location, the number of fibroids, the sizes of fibroids, and then where their blood supply is. It's also good for differentiating fibroids from cancerous tumors, particularly leiomyosarcoma. It looks at ovarian pathology, so ovarian cysts, possibly ovarian tumors as well, and then another benign gynecologic condition called adenomyosis. So fibroids are treated a lot of different ways. And we can go from medical management to surgical management to essentially expectant management, so not doing anything. Remember what I said earlier, a lot of women are actually asymptomatic, so you don't necessarily have to do anything. But in the symptomatic women, we think about, well, where are they in their spectrum of menstrual cycles? So are they premenopausal or menopausal or postmenopausal? So where we typically offer UFEs are the women who, one, still want to preserve their uterus, but as far as research goes right now, we're also offering it to women who do not want to have the ability to get pregnant in the future. So UFEs are, when I talk to women about UFEs, I tell them, well, look, this is another minimally invasive option that you have for fibroid treatment. Typically, these small pellets are put through blood vessels and essentially go directly to the fibroids to block off the blood supply to the fibroids. This is an outpatient procedure, so women typically go home a couple hours after the procedure is done. Bleeding-related symptoms typically resolve or are significantly improved in a vast majority of these women, as are mass-related symptoms. So remember, fibroids can grow to be really big, so they can put a lot of pelvic pressure or bulk symptoms on the bladder or on the bowel. And so, what the point of the UFE is to block that blood supply and then over time, hopefully shrink the fibroids. The procedure is good for women with multiple fibroids, and then the recurrence requiring repeat UFE is rare, so less than 5%, which is a pretty good outcome. Typically, surveillance after a UFE requires an MRI around 6 months after the procedure, and then again after a year. What I tell women after the procedure, typically it is like having a painful period for a few days as well as having the flu. And that can typically be managed with really good pain medication. Typically, I just recommend, if they undergo the procedure, high-dose NSAIDs, muscle relaxants, and a few narcotics. And typically that gets them through the first few days where it's really bad. Another benefit of this is that a lot of women are able to resume their normal activities after a few days to up to a week. One drawback of a procedure like a hysterectomy is you can't lift anything heavy or do anything to strain for a few weeks. And sometimes that's just not conducive to a woman's life. And so the UFE is certainly a good option for some women. So who is not a candidate for UFE? Well, if a woman has an active pelvic infection, so you may have heard terms or conditions like pelvic inflammatory disease, tubo-ovarian abscess, even STDs or infections inside the uterus, a woman should not undergo a UFE. There are certain bleeding problems like von Willebrand's or some other kind of hemophilia diseases that you shouldn't do the UFE for. Obviously, endometrial cancer, this is not the right treatment for that. Should not undergo a UFE if a woman is pregnant. And then again, there's still this question about fertility preservation. There's actually still not a lot of data on it. But for right now, we are not recommending it to women who desire future pregnancies. So some common questions: will I retain my fertility? Again, the data is lacking. There are not a lot of prospective studies. There are a couple of retrospective studies that essentially say that it might be okay. But for right now, the recommendation is not to have it as an option. Another thing about UFEs in women who are typically in their low to mid 40s is it might potentially bring on premature menopause. And then, are the particles safe? Are they permanent? Yes, absolutely. Some disadvantages: some do not respond to the treatment despite the technique. Up to 2% of the procedures are technically unsuccessful for whatever reason. And then again, the disadvantage of that, those first 3 to 5 days or so, we call it post-embolization syndrome sometimes, that can persist. The small chances of serious complications typically just refers to infection. But there are a lot of advantages, right? It treats all the fibroids at once. It is a minimally invasive option with a short recovery time, minimal blood loss, and for women, it can retain the uterus, which can have a significant psychological impact as well. So that's my quick spill about UFEs. That's typically how I counsel women about this treatment option for fibroids. Again, I'm a minimally invasive GYN surgeon with Erlanger Health System. I see patients right down the road at Erlanger East. So thank you for the opportunity to talk today.
It is great to have a wide variety of perspectives in how we do and take care of patients. My next topic is a pelvic congestion syndrome, and I'll take the slides when you're ready. It's probably one of the a very loose term that people use for pelvic pain, and as Dr. Dizon was saying, you know, there's a wide variety of different conditions that can cause pelvic pain. And so pelvic congestion syndrome really in this situation, we know that about 60% of patients with pelvic pain do not get a final diagnosis. We think that about 39% of women suffer with pelvic congestion syndrome throughout their lifetime, within their lifetime, and about 15% of female patients or females have pelvic congestion syndrome. PCS accounts for about 10% of GYN visits on an annual basis, and about 40% of diagnostic laparoscopy, and about 10 to 15% have hysterectomy for this condition. Essentially, what the problem is related to venous insufficiency. And just like we can get varicose veins within the lower extremities, when you have in the right panel veins that are flowing in an abnormal direction, they can enlarge and engorge and cause problems. And so pelvic venous disorders is really more of a topic that we're going to talk about, where development of varicose veins around the uterus and the pelvis that are due to venous outflow obstruction and or reflux are really the main drivers of the pain and dysfunction that patients can have. So we think that incidence is in women under 45 years of age, and they tend to have had multiple pregnancies. Now, in the diagram, you see the varicosities around the uterus and surrounding the ovaries. You see the left ovarian vein there with an arrow pointing down. There's reflux going the wrong direction. Venous blood should be going towards the heart, not away from the heart. And the areas of compression are at the two X's. The lower X is at the left common iliac vein, and that's where the artery compresses it. We talked about that before with Dr. Harris, the May-Thurner syndrome, and or if the superior mesenteric artery crosses the left renal vein, that can cause compression of that vein, which we call nutcracker syndrome. So the patients generally present with chronic pelvic pain that increases during their menstrual cycle, during intercourse, or post, and then standing or sitting for extended periods of time. Other symptoms could be irritable bladder, heavy menstrual periods, visible varicose veins in the genital region and legs, low back pain, hip, groin, and flank pain, heaviness, achiness in the pelvis and or lower extremities. Again, the differential diagnoses are very broad, and many of these have to be ruled out before we actually consider treating ovarian vein reflux. So as far as the pelvic venous disorders, Pelvic congestion syndrome can be related to ovarian vein reflux in itself, where the ovarian vein actually is flowing in the wrong direction and causing varicosities in the specific ovarian vein. It can be related to the May-Thurner syndrome with iliac vein compression and concomitant ovarian vein reflux. It can be, again, nutcracker syndrome, where the left renal vein's compressed, and that ovarian vein is the escape branch for the venous flow, which can then cause the varicosities. And then there's pelvic venous disorders, where there are different branches that escape from the pelvis that lead into the genital or vulvar region, perineum, and also into the upper thigh that are pelvic related. So there is a classification system for symptoms and varices and pathophysiology locations that if you really want to geek out on, you can find that at the Journal of Vascular Surgery under Dr. Meisner's report. And the diagnosis for this condition is based on the correlation between the clinical presentation of both history, physical, discussing with the patient, and then the findings of the venous reflux or obstruction on the various testing that we do. The pathophysiology, the ovarian and internal iliac veins have valves. The dilation of the ovarian veins during pregnancy or during the hormonal cycles can lead to valvular incompetence and retrograde flow. And then obstruction from either May-Thurner or the nutcracker, including the left renal vein, or even a retroaortic left renal vein, which can occur in about 2% of patients, can give a high pressure zone that causes the valves to fail and then retrograde flow to the ovarian system. This can be seen on ultrasound testing. This is very common. If we find an ovarian vein that's greater than 6 millimeters and we can elicit reflux, that's a positive situation for a patient. Here's an MRI showing a left-sided ovarian reflux with a very large dilated ovarian vein, and then the varicosities essentially surrounding the ovarian segment. Here's another drawing, and then also MRI finding of the pelvic congestion syndrome from the ovarian vein reflux. Now, the treatment for this is fairly straightforward. It's essentially an embolization technique where you pass a catheter into the ovarian vein and you place a coil. You can see the coils in the right panel that fill up that vein and actually occlude the vein to prevent the reflux from happening. There are some complications that can happen with this. Most people have perioperative pain that will last for 2 to 4 days. It does require narcotic medication. It's similar to when you have phlebitis in the lower leg and it's a painful phlebitis. They get that same kind of effect because you are essentially creating a phlebitic situation. And there's about a 2% chance where you can't embolize the coils out of the ovarian vein and into the venous circulation. So May-Thurner was discussed in detail with Dr. Harris. Again, you're compressing that left common iliac vein. And I want you to, this diagram I want to point out what happens to the internal iliac vein. So if that common iliac vein is compressed, blood is trying to go through that. Remember, we have about 2 liters per minute of blood flow through the vena cava. So there's about 1 liter per leg. If that blood can't get out through the common iliac vein, then it's decompressed through the internal iliac vein, which then goes through the connections from the ovaries and uterus to the opposite side. And so sometimes the treatment for the problem is actually repairing the May-Thurner syndrome. Commonly, if you have both iliac vein compression and ovarian vein reflux, we will repair the May-Thurner system first, and about 2 out of 3 times, that's all we need to do. Despite the fact that they do have ovarian vein reflux, their symptoms will improve. If they don't improve, then they also need to have the ovarian vein dealt with. Here's a CT image, 3D reconstruction of the artery crossing over the vein, compressing the vein. Here you can see on angiogram where the arrow is on the left panel, the high-grade 80% lesion, and then the compression on the right panel as determined by intravascular ultrasound. In these patients, oftentimes the compression is fairly high, so sometimes we actually have to double barrel the stents to actually control the region of compression, and that will actually fix the problem. Now, left renal vein compression through from the superior mesenteric artery, nutcracker syndrome, that can cause problems with the kidney, with hematuria, flank pain, but it can also cause pressure in the outflow vein for the ovarian vein. So if the ovarian vein can't decompress properly, you can damage valves, and then that's when the syndrome happens and the reflux occurs. And so as you can see in that diagram, the arrows are coming down the ovarian vein, the plexus is engorged, and that's the symptoms that they have. Now, other pelvic venous disorders we talked about in the left side, the May-Thurner syndrome. On the right side, you have the genital escape branches into the vulvar region or the perineum. You can also have problems with dilating veins in the perianal area with hemorrhoidal formation, and then extending through the pelvis into the upper thigh, which you can see. So sometimes these things are very hard to determine as far as where the source is. Generally, what we're looking for at that point is a point of obstruction that might need to be repaired to allow the patient to have reduced pain and symptoms. And so that's a fairly brief discussion on pelvic congestion syndrome, and we're going to move on to our last speaker for today on podiatric issues for women.
Hello, I'm Maria Pacheco. I'm a podiatrist with Chattanooga Foot and Ankle Clinic. Today we're going to be talking about podiatric issues in women, essentially with vascular necessity. So a little bit on the background, prevalence of PAD in women. It can affect anywhere between 5 and 10 million people in the United States, but it's been known to be more prevalent in women as age increases. In fact, there is a prevalence of PAD increase more as a function of age for women versus men over the age of 85, 39% being in women, 39% in women, 27% in men. A couple of the risk factors to identify in peripheral arterial disease in women. Women with diabetes will have a twofold increase of intermittent claudication. The presence of diabetes definitely increases the symptoms of peripheral arterial disease in women, particularly in the elderly population. Therefore, sugar control, A1C levels, it's paramount importance to keep those at a lower parameter. Women tend to have a lot of atypical presentations. There's significant gender-based difference in the prevalence of asymptomatic peripheral arterial disease in women, 13% versus 9% in men. Asymptomatic peripheral arterial disease is most common in the elderly female population, with up to 63% of elderly females with an ABI of less than 0.9, with almost no exertional lower extremity symptoms. This can be attributed to perhaps that women are less likely to complain about these peripheral arterial disease symptoms to their clinicians in routine foot evaluations or even with their primary care physicians. Women also tend to be older at the time of diagnosis, and a lot of these symptoms at an elderly age can be attributed to osteoarthritis, musculoskeletal pain from decreased activity level, and just overall increase in age. Women do face a higher functional impairment with peripheral arterial disease. In a recent study in Women's Health, the treadmill distance to onset of claudication was 33% shorter for females than it was for males. The maximum treadmill walking distance was 23% shorter for females and males with the same vascular burden. Therefore, with this result, we can determine that women and men with similar vascular disease burden we still see higher functional impairment on mobility in women. Podiatric evaluation signs and symptoms that we're looking for are pretty much similar to other speakers that have discussed this: pain, aching, heaviness, cramping in the legs. Patients can come in saying that their toenails have either stopped growing, they're yellow, discolored. They've noticed that there's thinning of the skin, discoloration. They may notice a loss of hair growth to the lower extremities. One foot may become colder than the other. Burning, tingling, numbness, which can be confused with neuropathic symptoms at times. So these are signs that we look out for whenever we evaluate this patient population. Raynaud's is a common one that we see in females, unfortunately. There's primary Raynaud's and secondary Raynaud's. The first one would be more attributed to females younger than 30. There's usually a familial history with this, and unfortunately, we don't know the cause of it. Secondary Raynaud's, we usually see it attributed with patients with rheumatoid arthritis, scleroderma, lupus, and Sjogren's syndrome. So podiatric treatment for Raynaud's is essentially identifying what could be causing it. Is it primary, secondary, maintaining body temperatures, creating an exercise regimen with these patients, because as we know, increasing exercises increases perfusion to the lower extremity, and examining even their current medications, migraine medications, decongestant medications, beta blockers. They've been known to trigger Raynaud's attacks. So being able to know their medical history and know what they can possibly change in order to trigger less of these attacks. So in my practice, I like to see these lower extremity pains. I like to perform comprehensive podiatric examinations on all my patients, whether they're being sent for routine foot care, a fractured bone. The point is that we want to make sure that we're evaluating these patients for any peripheral arterial disease symptoms. I like to complete a complete dermatological evaluation, identify if there's any hair growth, thinning of skin, color changes to the skin, clinical vascular assessment. We all tend to palpate pedal pulses, but a lot of our patients tend to be obese. They have lymphedema, just a lot of lower extremity edema where these are not palpable. So in my practice, I like to always have an in-office Doppler, a little portable Doppler to evaluate the DP, the PT, perineal, and its popliteal at times. I also like to do a test for neuropathy, monofilament test, light sensation. A lot of these peripheral arterial disease symptoms can be masked with neuropathy, and they can mimic one another. So being able to identify these symptoms is of paramount importance as they can exist together. And then, of course, in office, I always like to get routine radiographic evaluation. In advanced atherosclerotic disease, we can actually identify calcification of these vessels, particularly the PT, the AT, and the DP. So in this patient population, a nice x-ray that I can see in real time with the patient still in office with me, we can identify this sclerosis and refer out. So I'm just going to talk briefly about very short cases. The first one is a patient came in, painful ingrown. No major medical history apart from hyperlipidemia, hypertension. She was an everyday smoker. Prior to that, no lower extremity claudication, nothing major. She was self-treating at home for an ingrown of the right hallux and the right fourth toe. She came in, it hadn't improved. She was doing Epsom salt soaks. This was her clinical evaluation. So she has a little bandage on the fourth toe where she was clipping, but you can clearly see the cyanotic appearance of that right great toe. You can see where there's some underlying purulence at the distal medial border of it. She had delayed capillary refill time. All her digits were cold. She had a lot of tenderness to palpation, no hair growth, but prior to this, again, no claudication or lower extremity pain. Given that the patient had this severe ischemic presentation, I didn't do any podiatric procedure at this point. I didn't remove an ingrown. I started her on empiric antibiotics, and I sent her for a vascular workup. Her ABIs came back 0.59, monophasic waveforms to the distal PTA, flat digital waveforms, so she underwent a revascularization procedure. After the vascular procedure, she had better CFT, more perfusion, warm to touch, a little bit less pain, but she still had the ingrown. So at that point, I did a small slant back, very minimally invasive, where I just clip out the border of the nail, let it drain out without having to do an invasive procedure that goes to the root, increases her chances of an ischemic event. She's now a current routine at-risk foot care patient that I see every 3 months just to identify any potential problems, any issues that she currently may be having, but she's doing well as of now. The second case is one of those cases where we discussed late presentation, elderly. This is a 92-year-old female, had recently moved from Texas. She was coming in for diabetic foot check, just kind of routine evaluation. She was type 2 diabetic, hyperlipidemia, hypertension, and arthritis. No history of ever smoking. However, just a few months prior to my visit and her move, she was having pain at rest. She was starting to have calf pain. Again, she's 92. She was started on gabapentin by her previous provider, potentially for neuropathic symptoms. This was her clinical presentation. The right foot, you can see there's a little bit better perfusion. The left foot, you see erythematous changes, but the toes were distal, they were very cold to touch. She had eschar formation of digits 2 through 5. You can't really tell from this picture, but underneath the left hallux, she also had a lot of serosanguinous drainage, some purulent drainage. So I did send her for an MRI just to make sure that there wasn't any underlying osteo. Had no idea how long that had been going on for, neither did she nor her caretaker. I also sent her for a vascular evaluation. She was started on oral antibiotics. I took deep wound cultures prior to starting her on antibiotics. And then, again, she was seen by vascular. So she was classified as a Rutherford 5. She had triphasic waveforms of the common femoral, but everything was monophasic afterwards. So these were her diagnostic findings. Essentially, everything after the SFA was stenosed over 80%. Down to her foot, everything was stenosed 100%. So the patient, unfortunately, is high risk for limb loss. She's undergoing hyperbaric oxygen therapy, aggressive local wound care, and then I'm seeing her every 3 months again for maintenance and just kind of routine checkups. And as of right now, she's doing okay. So in conclusion, being able to identify the risk factors that are specific to women, understanding that this patient population will have atypical presentations and we will see them at an elderly age, so being able to identify whether this is a musculoskeletal issue or is this peripheral arterial disease related, and understanding that we do like to perform these comprehensive podiatric examinations. So if you have these patients with any type of lower extremity pain, that we do perform vascular assessments, dermatological assessments, everything from the knee down. The end. Thank you.